don't know if you saw, I
Everybody,
just sent you a little hot flash on the little.
listen. I sat here and I was like getting ready, and I was like, "Ooh, it's getting hot already. Let me turn the air up before she gets on here." It's
Okay.
crazy how they just come over you. So we are gonna get started. We are not gonna delay. Let me first say, what I need to say. The disclaimer here. Our session was developed by Vindico Medical Education with an educational grant support from Astellas and Pfizer Inc. More product information can be found in the link that I've posted in the comments. Dr. Kagan, please introduce yourself so everyone knows who you are and where to find you and all of those details. Thank you.
Okay, well, I'm Dr. Risa Kagan. Feel free to call me Risa. And I've been practicing menopausal medicine for over 40 years. I am a clinical professor at UCSF here in the Bay Area. I've also am a menopause, sexual medicine, and bone health specialist at Sutter Health here in Berkeley, California. I've done lots of clinical research. I do a lot of teaching, consulting, both to my colleagues as well as to all of you. I really enjoy educating the public and helping women navigate, especially this time of life. So thank you for having me and thank you for being here.
No, thank you. I appreciate you because I promise you, a lot of people probably didn't even know that there were medical professionals who focus specifically on menopausal health. So thank you, thank you, thank you. So let me just explain the format of how we're going to do this. It's going to be a short Q&A session. I have some questions that I'm going to ask, but once again, everyone, if you're on here and if you have a question, by all means, put it in the comments. And hopefully we'll be able to get to it. If we can't get to it during this live, I will do my best to get an answer from you and share it with you later. So let's get started. So most of you all know, if you've been following me for a while, I am a breast cancer thriver. Every month, I try to come on here and remind you the importance of breast health. What I want to know is, what are the changes that people will see to their breasts during perimenopause and
Okay.
menopause?
Well, that's a very good question because people don't understand that. The perimenopause, remember, are the years around that final menstrual period. Once you've gone 12 months and look back, that you are now postmenopausal. The perimenopausal years can wreak havoc on your breasts because your hormones are fluctuating. And I tell some women they have, what they feel like are hot rocks all month long. They, believe it or not, your breasts can sometimes be very tender. And many women will come in and say, well, if my hormone levels are dropping, how can my breast be tender and my tender? Because you're basically, there's a feedback loop between your ovaries that are producing estrogen and this brain area, okay, up here in the hypothalamus. And this area is reading lower levels of estrogen and it's saying, put out more, put out more. So it's pushing your ovaries to sometimes put out a lot of estrogen. So some women will have actually increased levels in the perimenopause and they have breast tenderness, so they hurt. But with as time goes on, okay, and you become lower and lower in your estrogen level, your breasts become less sensitive, less tender. And believe it or not, in postmenopausal women, mammograms are more accurate because your breasts become less dense and you have more fat tissue. Your breasts are made up of lobules, which are the breast glands, ducts, it's kind of like a grape, okay, and fat in between. Everybody has that. And we see it on a mammogram. And as women age, mammograms become actually more accurate because you have less dense stimulated breast tissue from estrogen. So that's something women don't know, that postmenopausal women actually, that's why in younger women who have dense breasts, sometimes it's very hard to read mammograms and we need to make sure you have 3D mammograms or have an ultrasound, or sometimes we have to do even MRIs. So it is, there are breast changes that occur.
That is good to know because I'm certain, I know I didn't know that, and I'm a breast cancer advocate, so I try to know as much as I can, especially about our breast health. I had no idea that because your breasts, as you get older, they're more dense. That is a great tip, and I hope that that's something that the next time a woman is with her physician, she does discuss that, because we see a lot of people making comments about having dense breasts and being identified as having dense breasts, especially at a young age. So
Right.
my next question is,
Less dense. I just want to make sure that as you
yes,
get
less dense.
less,
Yes, yes, yes. What can you tell us about the risk of breast cancer as it relates to when a woman experiences menopause?
okay. Well, we all know that there's the main risk for breast cancer is being a woman and getting older. Those are the two big risk factors. Okay. But it has been shown that women who have a later menopause, like, late 50s, where that's their final menstrual period, they've had longer years of estrogen exposure endogenously from their own hormones. So somebody who has a very early menarche period, their first period, and later menopause, those are women who are we can't do anything about that. That's, biology, genetics, who have basically slightly higher risk for breast cancer. On the other hand, when women, okay, get pregnant and they nurse, all those conditions reduce people's risks of breast cancer. So there's something related to, hormones, obviously.
Yes.
But there's also genetics and environmental factors and a lot of other factors.
Got it. Yeah, just it sounds like, basically what it is anyway. And it's really kind of really about us taking note of what's happening with our bodies. I think oftentimes things are happening and we're kind of like, oh, we just don't think
Don't
about it or take note of
right.
it. So when we go to the doctor, we often forget to say it. So I actually have a notebook where I write everything down. So I'm spending lots of times in my doctor's office making certain. I'm like, listen, the other day my foot was tingling. Why could that have been happening?
Right.
And so I think it's very important that we start to take note for that reason. Can you tell us about how the treatments for breast cancer can trigger menopause symptoms?
Okay. Well, it depends on your age and what kind of treatment you're going to have. We have multiple kinds of treatment. Okay. Doing a lumpectomy or even a mastectomy, that's something different. Radiation, that's something different. But for premenopausal women, who we usually do something called adjuvant hormonal therapy with a drug called tamoxifen. And that sometimes can mimic some of the symptoms of menopause. It usually doesn't make somebody go into menopause, okay? But sometimes people can have vaginal changes, vaginal dryness, or a different discharge, and even having hot flashes. Postmenopausal women, some do use that drug called tamoxifen, but more recently, people use something called an aromatase inhibitor, which is blocking any of your own production of estrogen, not only from your ovary, but believe it or not, we produce a little bit of estrogen in our fat cells, and it blocks it there as well. So all of that can cause lower levels of estrogen to the point where people have hot flashes, they have drier, thinning walls of the vagina called genitourinary syndrome of menopause. And they also can have joint pains a lot. Now, it's important that you really have a good relationship, not only with your women's health provider, but your oncologist who's giving you these drugs, because there are many alternatives and you might have to go from one to another to another. Now, there are some women that end up needing chemotherapy. And when you go through chemotherapy, depending also upon your age, that can throw you into menopause, an earlier menopause than you would have had anyway. All right. Or you may even go through menopause temporarily, where you are low levels of estrogen and have all those symptoms. And then when you finish your treatment, sometimes women do have return to some hormones. It really depends on how old you are when you are being treated. So, and we usually don't give, I know a lot of people will ask about this. Generally, we do not give hormone therapy, estrogen, and the progestogen to women who are breast cancer survivors, or uterine cancer, endometrial, which is the word for uterine cancer survivors. Any estrogen-dependent tumor, we wouldn't want to give estrogen to. But we do have alternatives, and we have our own special clinic now for cancer survivors. But if somebody had, say, leukemia, lymphoma, somebody had colon cancer, they were treated, and it put them into menopause because they had chemotherapy, that person generally can be on hormone therapy. That's not a contraindication.
That's interesting. And I'm glad you stated that. First, I'm also glad that you stated that some of the other, if you don't necessarily have chemotherapy, you can mimic those symptoms and it may not necessarily be menopause. What's very interesting is the talk in the breast cancer community is when you are showing those symptoms, oftentimes that's what they say. They're like, oh, it's menopause, it's perimenopause. And it kind of becomes a discussion of get prepared because you're probably not going to have a cycle for XYZ amount of times. And then oftentimes your cycle does come back. And I think that's where a lot of the confusion comes in. Now, when you add the chemotherapy, that does definitely make a difference. As for me, in my case, I was definitely kind of like pushed in the middle because at one point I was definitely perimenopausal, and then I didn't have a cycle for an extended period of
Right.
time. So the doctor was like, oh, it's menopause. And then I feel like 2 months later, I went back and was like, well, let's talk about
Yeah.
that. And she's like, oh, well, wait a
Well,
minute. And you're right. It is very important that there is a great relationship between your oncologist and your primary, because you all need to be in discussion about what is happening to your body as a whole. So you want to treat you as a whole. I am
yes.
so
And
glad
there
you
are
said.
so many effective therapies. We have this clinic, a menopause clinic, and also specific to breast cancer survivors because they can't use what we normally would give. We have many alternatives. And you can even learn about those alternatives at the Menopause Society website, www.menopause.org. They have a list of all the other alternatives, both pharmacologic as well drug wise, okay, as well as some lifestyle changes like cognitive behavioral therapy and some other ways in which you could be treated. But we have very good, not as good as estrogen, but they are very good. So for instance, if you can't sleep at night and you're having joint pains at night and you're having hot flashes at night, many of us will try gabapentin, which is a medication in very low doses. Higher doses we use for epilepsy and nerve pain and ruptured discs, but in lower doses, it's been shown to be effective for hot flashes and for sleep. Okay. And for some women, it even can help mood and be mood stabilizing. So these are called off-label use. We use lower doses of the anti-anxiety and antidepressants, which a lot of women don't want to do, but I say to them, hey, you've got to feel better to be able to live life and have a good quality of life. There's no reason to suffer. And so many a time we will do both. We'll give something in the morning, and then we'll add something in the evening, but you shouldn't be hurting and suffering. And then we need to talk about the vagina, because the genitourinary syndrome of menopause, all breast cancer survivors need to start knowing about lubricants and moisturizers. There are lots of non-hormonal lubricants with sexual activity, moisturizers, like you moisturize your skin anywhere in the vagina 2 to 3 times a week. And we try that first. And if that doesn't work, most oncologists do let us prescribe a very low amount of local in the vagina, a bit of estrogen. After you've tried the others, you can't suffer. We have these young women who are in their 50s who have vaginas like 80-year-old women. That's not right.
Yes,
Um,
absolutely.
right.
Yeah.
So, I mean, really, somebody's here asking. I just have to bring it up.
Yeah.
What's a
Go
little?
for it. Yeah.
I'm taking 203 times a day. That's low dose. The study for hot flashes that was studied by an oncologist for breast cancer survivors was 303 times a day. We never start that right away because people will be dizzy, somnolent, and feel foggy brain. Usually we start at bedtime with 100, then we slowly go up to 200, then to maybe 300, or stay at 100 if it works. Then you add the daytime dose. 2 times, 100, and then midday if you need it. Some women only need twice a day. Some women only need it, a few times a day, but 1 to 300 3 times a day is what's considered low dose gabapentin. Somebody asked that, so I thought I'd answer it.
Yeah, no, absolutely. I'm glad you answered that. And so I think it's also very important that we note, we are seeing that women are getting breast cancer younger and younger and younger. And
Absolutely.
what's happening is, sexual health is
Woo!
important. And, sometimes women are a little, they don't want to tell their doctor, this is what's happening because they don't really see it as an important symptom. But it really is
Oh,
because it
no,
will affect your overall life.
totally. And there's study after study about quality of life,
Yes.
self-esteem. You know, many younger women, especially, just want to live. They have small children. They're
Mhm.
like, put the sex and the back burner. But your relationship is really important to yourself and your partner. And we are encouraging our nurse navigators to bring it up, even if the patient just ask,
Mm.
because they can start using moisturizers, lubricants early on, because you really want to start living life again and having, you know, your relationship go on. You're going to live a long time. Most women with breast cancer get cured. So you just keep
Absolutely.
that. Yeah.
I am so glad you said that. And I am going to make certain that I repeat that message consistently throughout the community, because when we all get together, that is something that we talk about. You know, we show each other our breasts, you know, because everybody's
Right.
breast is different, but we also talk about sexual health, and just kind of like how we feel about it, and, you know, our self-esteem, how we're feeling about our bodies and all of that. And I tell them all the time, you know, this is a discussion also that you need to be having with your physician, because it is important to your overall being. So, while we're on that topic, I want to talk about risk and benefits of hormone therapy for breast cancer survivors as well.
Well, as I said earlier, the majority of clinicians and oncologists are not comfortable having breast cancer survivors being on hormone therapy. Okay. Local vaginal estrogen and very low doses. And there's a super low little suppository where there's studies looking at, you know, the absorption, but that's different. Many of them will allow that. But to be on systemic hormone therapy, most would endorse not doing it. And, you know, have I ever done it? Yes, occasionally. If somebody is 10 years out and they've tried everything else and they have come in and saying, this is what I want, and they have a real, you know, discussion about the risks and the benefits, I think there
Mm-hmm.
is concern about recurrence. There is, especially if you're estrogen receptor positive.
Absolutely.
You know, I think that is, it's not like a blanket answer for all women, but many people are concerned about giving hormone therapy. But have we ever done it? Yes, I think there, in certain cases, people will have go around and basically get lots of opinions. But for some women, and especially some of the younger women, some feel that the benefits outweigh the risks. But we have many alternatives to estrogen for cancer survivors, breast cancer survivors.
Okay. And so, what about the non hormonal therapies? Because I think that you're right. A lot of us are afraid. And even though for me, my cancer was not estrogen receptive, it was triple negative, I am still very mindful of anything that I think could trigger or cause a recurrence. So,
Right.
what about the non hormonals?
Or another breast cancer. I mean,
Yeah,
that's the, you know,
absolutely.
so I think that's one of the problems. Vaginally is a different story. I think many of us would give, especially if you're years out. Okay. And, but as far as quality of life and for your bones, you get a bone density, and we want to follow you every few years. We have many, many drugs to prevent bone loss and to treat people who have low bone mass or osteopenia and osteoporosis. And some of those drugs that we give, the aromatase inhibitors,
Mm-hmm.
cause this. So while you're on those, we often do give some of the other drugs. For hot flashes and for sleep, we have many alternatives. A lot of women need to be on the SSRIs or SNRI drugs, which is like the anti-anxiety, antidepressants, for both low doses for hot flashes, as well as sometimes anxiety and mood and depression. Like, face the facts. You've been diagnosed with something that makes you think about, you want to think about the here and now,
Mm-hmm.
and you can't stop thinking about, where am I going to be 10 years from now? So a lot of this can help. Again, as I said, we have medication for gabapentin, which is often used, especially for nighttime. One of the off-label uses that works very effectively, there's a drug that we have out for overactive bladder that works on the nervous system, called oxybutynine. And that actually has been published by one of my colleagues in our data on a randomized trial against a dummy pill as being effective also for hot flashes. They're all, and now there's also a new drug that is just approved this last year called Veoza, okay, specific to hot flashes. Hot flashes efficacy and safety has been studied in the area of the brain and something called the candy neuron. Now, I know the mechanism of action of this, and most of us feel it's perfectly safe in cancer survivors and breast cancer survivors. But I will be honest with you, none of these studies allow breast cancer survivors to be in these trials. So we have encouraged the company to do studies, when we consult with them, on breast cancer survivors because we want to know, does that drug work just as well on an AI or on tamoxifen? I think it'll work if you're not on those drugs, just like it will on the women, any woman, but for hot flashes only, okay? But it is quite effective as an alternative to estrogen for hot flashes. So we have many options for women. They should not be suffering.
Absolutely. I love that you said that. I mean, literally, you should not be suffering. So I had someone send me a question earlier and they asked me about Lexapro. Are you familiar with
Yes,
it?
of
Like,
course.
is it something that
Lexapro,
people are getting
yes,
prescribed?
yes. Well, Lexapro, Prozac, Zoloft, a similar drug, Celexa, Effexor, which is a little different. It's called a selective, it's SNRI. They've all been studied in small studies as an alternative to estrogen for hot flashes, and mostly in the breast cancer survivor world where they can't use estrogen. And there is efficacy over placebo, like the dummy pill. The problem is that there's generics for them now. So they haven't gone to get the official indication. The official indication is anti-anxiety and antidepressant. But let's face the facts. Many people who get diagnosed with cancer, they should put it in the water. I have to be honest, especially in the beginning when you first get a diagnosis, because it's really hard. You have a lot of anxiety, a lot of fear. We need you to sleep. We want you to be healthy. Sleep is essential for all of your body parts. And we know that. So a little Lexapro, if that works for you, that's fantastic agent for both mood, anxiety, and hot flashes for women who are survivors.
That's good to know. And I'm glad you mentioned sleep because you're right. When you're diagnosed, and I don't even want to just say it's for newly diagnosed. And I also think that what happens is, so I'm 10 years out at this point, and for me, there was no maintenance drug. So anytime I have to go in for a scan, I always have scan anxiety. And we talk about that all the time. We're like, pray for me because I'm going in to get a scan. I don't know what it's going to look like. And we're looking at the technician that she's doing the scan, trying to see if she sees something. So
Right.
I agree that I do think that these drugs should be something that is a part of the discussion, as a part of the treatment plan. And I hope that everyone that's listening here is really paying attention. And when they go for their next appointment, or even don't wait, call your doctor tomorrow if you have any questions about this and get some answers, because as she stated, you do not have to suffer. So it looks like we're out of time, unfortunately. I could do this all day long. I want to thank you so much for
Thank you.
all the information that you are providing and all the work that you're doing. Can you let everybody know again where they can find you and share the website where they can go and get more information?
Okay. Well, I think the Menopause Society website is fantastic at www.menopause.org. But there also are many sites, the National Cancer Network. There's a lot of, breast cancer survivorship programs and where you live. And I would really, in the American Cancer Society, but there are a lot of programs. But to learn about menopause in general, probably the most accurate, evidence-based is the Menopause Society at www.menopause.org. And they do have videos there. They have a lot of programs for consumers. And you can even find a practitioner there that at least is well versed in the menopause world and knows something. And they're not all doctors.
Okay.
Sometimes doctors are the worst. Many of them are nurse practitioners and PAs. Really, your nurse navigator sometimes in a cancer center knows more
Yes.
than, okay, they are really your
Yes.
partner in getting you to the right
Yes.
people. So,
Absolutely. I could not agree more. My nurse practitioner and I are like best friends.
yes.
Love her to death. Thank you so much for putting that website in there so that people see it, Buffy. I
Okay.
appreciate that. So, once again, thank you so much for this discussion. Guys, we don't have to suffer, so stop doing it. Make certain that you watch this again if you need to, if you didn't take notes. Once again, if you have questions that did not get answered, feel free to send me a DM and I will get the answers for you and then share them. Dr. Kagan, thank you so
They're
much and have a great night.
all. Bye bye.
Bye, everybody.